Hello, everyone. I'm very pleasure to have this chance to introduce our work. I'm Yaping I am a pediatrician from Department of Pediatrics, affiliated hospital of Jiangnan University, China. My major is pediatric endocrinology and metabolism. Now, today's my talk is Noval Compund heterozygous mutations of PCNT gene in MOPD type 2 with central precocious puberty. This is a very interesting case. And this case report has been published in Gyneco-Endocrinology. I will follow these contents. Microcephalic osteodysplastic primordial dwarfism type 2, MOPD2, is a highly harmful autosomal recessive genetic disease characterized by intrauterine growth restriction, postnatal growth defects, and microcephaly. It is mainly caused by the functional mutations in PCNT gene. The PCNT gene mapped to 21q 22.3 spans 122 kilobytes of genomic sequence and contains 47 exons. It encodes precentrin, a critical centrosome protein. Precentrin comprises 3,336 amino acid residues. Precentrin serves as a multifunctional scaffold for entering a wide range of controsomal proteins and protein complexes during cell division and interacts with G-tubulin, which is required for microtubule nucleation. The phenotype caused by PCNT mutations might reflect a role for spindle dysfunction in MOPD2. The disruption of precentrin can lead to mislocalization of proteins and cause mitotic spindle defects, chromosome misaggregation, mitotic failure, cell arrest, and all cell death. Now, let's see this case. This is a 6-year and 11-month-old girl. She had severe growth retardation. Gestation age is 37 weeks. Birth weight 800 grams and body length only 33 centimeters. Apgar score was 2 to 9 points and 1 and 5 minutes after birth. She was fed with infant formula. Frequent vomiting for 7 to 8 months. She grew slowly after 1 month old. Thyroid function normal and chromosome karyotype was normal too. And the height was 82.2 centimeter, and the weight 7.7 kilogram. Microcephaly, probasis nose, small teeth, white teeth crevices, irregular dentation, left breast 10-2, pubic hair 10-1, axillary hair 10-1. Let's see this child. Now this is this child, very short stage, and her height is only 82.2 centimeter, and she had microcephaly, proboscis nose, small teeth, hyperglycemia, enamel, irregular dentation, whiteness of crevices. This is the this is the left breast, a little bit development, and it was turn 2. It indicated that this child has the precocious puberty. This is a puberty here turn 1, but her skin is very special. She had a skin pattern like a clinic shock case. So the primary diagnosis for this kid, short stage, precocious puberty. Let's see the labs. The peak growth hormone was very high in growth hormone stimulation test, and IGF-1 and IGF-BP3 a little bit high. Peak luteinizing hormone and follicle stimulation hormone in tryptophan stimulation test were 8.97, more than 5, and it showed that the HPGA of this child was activated. Let's see the OGTT about the glucose and insulin. The insulin were normal, but the glucose a little bit high, especially at the 120 minutes and 108 minutes. A little bit more about 5.6. The blood lipid analysis, electrolyte, thyroid function, glycosylated hemoglobin, liver function, renal function, hepatitis B, cortisone, ACTH, HCG, AFP were all normal. Bone age 8.4 years old, more than her age. Brain scan was normal, and electrocardiogram and echocardiography were all normal too. B ultrasound showed the normal abdomen, adrenal and thyroid. Pelvic ultrasound showed the volume of the uterus and the ovaries a little bit bigger than her height and her age. After communication with the parents, this child's parents agreed to do the gene test. The gene test said PCNT C1828 WT insertion mutations was found in the girl and her father, but not her mother. PCNT C1207-1GA splice site mutation was found in the girl and her mother, but not her father. So the final diagnosis is MOPD2, central precocious puberty, impaired glucose tolerance. So let's review the literature of this disease. What's the MOPD2? Or how about the PCNT gene? PCNT plays a critical role in the formation of central and mitotic spindle and participate in the periodic cell activities by recruiting other proteins to the precentral matrix. PCNT gene mutations are associated with many diseases, including MOPD2 and Secure syndrome. Loss of function mutation of double allele in PCNT gene leads to MOPD2. Most of our loss of function mutations in PCNT were double allele single nucleotide mutation. However, we reported a novel compound heterozygous mutations in PCNT gene, splice site mutations at C point or 12071GA and an insertion mutations at C1828 PS6110 FS32, both of which were inherited from healthy carrier parents. According to the criteria and the guidelines for classification of genetic variations of the American Society of Medical Genetics and Genomics, the mutation site at C12071GA is a splice site mutation, which would have a great impact on protein function. The mutation at site 1828 duplicate is an insertion mutation, which results in the change of the amino acid PS6110 FS32 and premature termination of protein translation. These two new heterozygous mutation of PCNT mutations and the typical intrauterine and postnatal growth retardation, the child was diagnosed as the MOPD2. In addition to the most common severe short stage, it is not uncommon to see different system abnormalities in MOPD2, such as there's reported a 3-year-old boy with MOPD2 was paralyzed due to cerebrovascular malformation. Another MOPD girl was abnormal jaundice and acute cerebral infarction, had a stroke at the age of the 8 months, and hemiplegia at the age of the 18 months. MOPD2 case with subarachnoid hemorrhage and multiple intracranial aneurysms has also been reported. In our case, no cerebral vascular problems were found by MRI scan. And in addition to the central nervous abnormalities, MOPD2 can also be associated with abnormal cardiovascular and dental development. In our case, we did observe tricuspid regurgitation and serious tooth abnormality. It has been reported that in patients with PCNT gene mutation developed severe insulin resistance, diabetes, and dyslipidemia. In this case, impaired glucose tolerance was also present. Severe insulin resistance and early onset diabetes are common features of PCNT deficiency. In a study, precocious puberty has been reported in 6 of 21 MOPD, 2 females elder than 8 years old. Those cases were also accompanied with severe insulin resistance. While insulin resistance was not present in this case, most central precocious puberty cases are idiopathic, but some are caused by mutations in KIS1 receptor, MKRN3, or DLK1 gene. However, our gene sequencing data did not reveal these reported gene mutations. In addition, MR scan did not show abnormal pituitary and cerebrovascular in this case. Whether the central precocious puberty in this MOPD2 is related to the Noval Compund heterozygous mutation of PCNT needs further study. Up to now, the treatment of the MOPD2 is controversial. After communication with the kids' parents, the kids' parents decided to start the treatment. On October 15, 2018, the kid began to treatment. Then with the GIGA and GH. 3 months later, the height increased a little bit, and the disappearance of memory knockers, and the peak LH decreased. IGO1 and IGO BP3 a little bit high, and the OGTT showed OGD test showed that glucose and insulin were normal. This is the height change of this kid. About the 11 months after treatment, the parents decided to give up treatment. And during these 11 months, the kid's height began from 82.5 to 87.7. We calculated the growth velocity equal to 5.7 centimeter per year. This is a bone age change, a little bit bone age change. And it said the GIG controlled the development of the kids. It is efficiency. 1 year later, after the last treatment of this kid, I telephoned the parents of the kid. The mother told me this kid has the menarche. The first menarche time is September 1, 2020. About the kid's age is 9.1 years old. So let's summary. MOPD2 can be associated with central precocious puberty and impaired glucose tolerance, in addition to intrauterine growth restriction, postpartum growth defect, and microcephaly. The use of GH is controversial for those cases. Thank you for your attention. It's our new hospital. Our hospital is in Wuxi City, China, a beautiful city. Thank you.
Now the session is open for questions. If anyone had any questions, please